Okay, now we have a very interesting topics. Our presenter now is a very renowned, world-renowned laparoscopic surgeon. He's the past president of Malaysian Obstetrics and Gynecology, and he's also past president of the APEG. He's a very renowned laparoscopic surgeon and fertility specialist. This is Dr. Silveraza Supermanium from Malaysia. He'll speak on high intensity focused ultrasound, a new hope in the management of adenomyosis. I would like to invite Dr. Silva. Sir, you can start.
Okay, thank you. Thank you for this invitation. I'm going to give this talk and I'll call it HIFU, a new hope for the management of adenomyosis. Now, my disclosure is I run this ultrasound-based HIFU center in Malacca, Mahkota Medical Center, Malacca. Actually, I've given a similar talk during the Bangladesh Fertility Society, but that is on my experience. So here I will concentrate on adenomyosis and how HIFU can help women who have adenomyosis. Now, I'll give you a case study. This is a lady, a 39-year-old lady, married for 9 years with no children. She has adenomyosis with severe period pain and heavy menses. I think we all see this kind of patients. She has been admitted for blood transfusion many times because of this severe bleeding. And she saw me in February 2019. And this was her uterus. You can see that usual typical adenomyosis, large adenomyosis, 6.8 times 6.9 centimeters. And so I told her that there are not many options for her. She can do adenomyomectomy, which is not a surgery I like to do, but there is one choice. Or she can do hysterectomy or HIFU. She said that she will wait for HIFU, but there was a delay in bringing HIFU to Malaysia because of the COVID. And so she couldn't stand the pain. So she actually underwent a laparoscopic hysterectomy. This is her surgery, a laparoscopic hysterectomy surgery. Let me see whether I can play this video. It's a big uterus, around 18 week size uterus. Otherwise, there was not much addition, so the surgery was actually fairly straightforward. So here I'm suturing the uterine arteries on the right side, and then this is the suturing the uterine artery on the left side. I routinely usually suture my uterine arteries because we can see things better. Then we are excising the uterus. These are cutting the vagina. And then the hysterectomy was performed. Okay, so here the uterus was detached from the vagina. And after that, we repair the wall in the usual manner. And the uterus was so big that I had to actually cut it into small pieces. So I usually use a knife, and because the uterus is too big to come out and they never delivered before, I had to cut it. And you can see how bad the adenomyosis is. So I usually use a knife. It's called it's just a knife on a 10 millimeter trocar, and then we remove it. So here the uterus is being removed. So after removal of this uterus, the uterus was removed, and then the wart was then sutured in the usual manner. So here I'm suturing the wart. So this is a typical case scenario. I think many of you gynecologists will have this kind of patients who cannot stand the pain. After much, they just give up on their pregnancy and have a uterus removed. Of course, removal of the uterus will solve their problem. And this is the uterus that is removed, 625 grams. So now, can we do anything for these kind of patients to avoid a hysterectomy? So this is what my talk is going to be today. Now, when we look at adenomyosis, there are two different types of adenomyosis. Usually we call it a diffuse adenomyosis or a focal adenomyosis. A focal adenomyosis, we call it adenomyoma, usually is located in one place that we can actually do an adenomyomectomy, but diffuse adenomyosis is usually difficult to do anything. This is a very good book by a friend of mine, Dr. Felix Wong in Hong Kong, on adenomyosis. If you want to, you can read through this book. Now, there are many different types of adenomyosis. If you do MRI, we call them diffuse, internal, external, and adenomyoma. And I'll tell you the classifications. We look at this. This is the classification, MRI classifications for adenomyosis. And first classification is adenomyosis, internal adenomyosis. That is adenomyosis inside, and this is focal adenomyosis, superficial adenomyosis, and diffuse adenomyosis. And these are the internal adenomyosis, and these are the diffuse adenomyosis. Then we have adenomyoma. There are different types of adenomyoma. You can see the intramural adenomyoma. You can have a cystic and intramural adenomyoma, you can have submucous adenomyoma, you can have subserosal adenomyoma, and then you come to these external adenomyosis, which are the most difficult ones, because these external adenomyosis are the ones that either attaches itself to the rectum or attaches itself to the bladder and causes a lot of problems. So different types of adenomyosis. So you must understand that any form of treatment also, it depends on what type of adenomyosis one has, including HIFU. So now when you look at this adenomyosis, the types of adenomyosis, we actually see two types of patients. I usually see two types of patients. There are those patients with adenomyosis who do not want to conceive but want to retain their uterus. So these are the patients who have delivered babies or they have given up on getting pregnant. So they want to retain their uterus. The others are those adenomyosis who want to conceive. And this is important because afterwards, when I'll let you know that when we do HIFU, these two patients have different ways in which we treat the adenomyosis. Now, those who do not want to conceive, what do we have? What choice do we have? We can give them oral contraceptive pills. We can give them Dynogest. We can put Depo-Provera injections. We can put in Mirena. We can give intermittent GnRH analog, or we can do a hysterectomy. Of course, hysterectomy will cure the condition. Whereas those who want to conceive, we have very few choices. We can either do an adenomyomectomy, and you all know that this is not a very nice operation to do. It's a difficult operation to do. Or we can give them Dynogest or GnRH analog followed by spontaneous pregnancy. We have some success with this kind of patients. I have had patients who have who want to conceive we give them GnRH or Dynogest, and after sometimes they can either spontaneously get pregnant or we can do a frozen embryo transfer. One strategy in patients who want to conceive with adenomyosis is actually to collect their eggs and freeze the embryos, and then we give them GnRH for 6 months to 8 months, hoping that the uterus will become smaller, and then we transfer the embryo and then they get pregnant. This is a strategy that a lot of us have used, but not everybody gets pregnant, and that's where the problem comes in. So what is HIFU? HIFU stands for high intensity focused ultrasound. Basically, we are using a focused ultrasound beam to ablate the adenomyosis. That's basically what we are doing. And this is the video. I've shown this video many times.
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focused ultrasound, HIFU, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body without causing any damage to the overlying surrounding tissue.
So that's basically what HIFU is all about. Basically, we're using ultrasound beam. We put it into a tight focus and then we coagulate the area where the fibroid or adenomyosis is going to be. Okay, so there are actually two different types of HIFU. The first type is called the MRI-based HIFU, and the second, which is made by Philips and GE, and this is how it looks. And the second one is the ultrasound-based HIFU, which is what I'm doing. It's actually from China. It's from Chongqing, China, and this is the machine that I'm using. It's called JC200. Now, what are the difference between the two? Many of you must have heard about HIFU, and you heard that it is actually not so good. And that's what I heard for many, many years. I thought MRI HIFU is a waste of time. And there are actually two different things about these two HIFU. First of all, you can see that the transducer are different. So firstly, this transducer, the MRI-based transducer is limited in size and has a hole in the gantry of MRI. Whereas the ultrasound-based HIFU, the movement of the transducer is not limited. They are two different. This is in a hole. You know how the MRI looks like. This sits in the hole. This transducer doesn't move very well. This one is a transducer that is an open system. It actually can move. It can move 6 centimeters on this side and can move 6 centimeters on any direction. Another difference is that this HIFU, the transducer is different from this transducer. The MRI-based transducer is called a phased array transducer. Actually, basically, it has got a lot of small transducers. The advantage of this is that this transducer is that the focus can be moved without moving the transducer. So, I mean, this actually, you can move the focus from one point to another. That is very good for MRI-based HIFU. But the disadvantage is that the focus of the phased array transducers is by these 256 small focal points. So the intensity of the concentration is not so good. And so the power of the machine is limited. So the power in which you can give from this is far smaller than this. This is one transducer, but it can give a power of up to 400 watts, whereas you can't get that kind of power with this. So that's the reason why the power of the machine is far better in an ultrasound-based HIFU compared to the MRI-based HIFU. But the biggest advantage is that not only because of the power, this HIFU is actually done under MRI. When you do MRI, you cannot do it live. That means when the machine is shooting the beam, which actually takes 10 to 20 seconds, the patient have to keep quiet, and for 20 seconds she has to stay still. Whereas here we are doing every shot as 1 second, and it is done under real time. We can actually look at the uterus while we are shooting. So the safety margin for an ultrasound-based HIFU is far better than MRI-based HIFU. So that's the two difference between these two. Okay, let me see. Okay, so therefore the advantages of ultrasound-based HIFU, as I've said again, is that it's a real-time ultrasound imaging while you perform the HIFU. We use larger and more powerful transducers, better transducer movement. As you can see, the transducer moves much better here than it moves here. And also a shorter operating time. Because of that, we can do it faster. And the success rate is the most important advantage, especially for uterus and for uterine fibroid and adenomyosis. We get a larger area of non-perfusion with ultrasound-based HIFU compared to MRI-based HIFU, because MRI-based HIFU is non-real-time, and we have to have a large safety of margin to ablate. You cannot go very close to dangerous areas. In this case, we can. So the benefits of HIFU for adenomyosis patients is it's non-invasive. When shrinkage of adenomyosis occurs, the uterus will become smaller and is more amenable for pregnancy. There's a reduction in the symptom, namely menorrhagia and dysmenorrhea. The patient can start conceiving after about 4 months of treatment. And the patient can even have a normal delivery after the treatment because there's no scar in the uterus. We do an adenomyoectomy. I don't like to do it because I'm always worried that the patient will have a uterine rupture if she gets pregnant. Whereas here, we don't have to worry about that because we don't have any scar in the uterus. There is no worry about uterine rupture. Now, but there are a lot of challenges when we do HIFU for adenomyosis. In patients who do not want to conceive, we can do extensive ablation can be performed, and this can include the endometrial cavity. So the success rate in reducing symptoms is much higher if the patient doesn't want to get pregnant. Whereas if the patient wants to get pregnant, we have to be very cautious. We have to only ablate the adenomyosis. We have to be careful not to accidentally ablate the endometrium. And so the symptom release is lesser because we use less energy as well. So this is the two differences between these two types of patients. So I'm actually very happy to do this, but I'm seeing more and more patients with this because I'm a fertility specialist as well. And I know all the fertility specialists in my country, and they send the patients who have failed IVF and have a large adenomyosis, and they send them to me to try to shrink the uterus so that they can have pregnancy by either frozen embryo transfer. So patients also with prior surgery may have intestines adherent to the uterus, and this is also a big problem. And this may be in the path of the HIFU beam, and so success rate we cannot do HIFU for this kind of patients. So like, for example, this is an example of a patient somebody sent to me, previous myomectomy, huge recurrent fibroids, huge fibroids. Here the intestines were just stuck on the uterus here, and here I'm doing a laparoscopy. So we rejected this patient to do HIFU, and we went and did a laparoscopy because when there's an intestine covering the fibroids, we can't do HIFU. Now, I started performing HIFU in 12th of July 2021. So far, we have done 105. Until yesterday, we did 105. After this lecture, I'm going to do my 106 case. We have done 55 adenomyosis cases, 47 fibroids, and 8 adenomyosis. And there are a lot of experience we have from this HIFU. So this is my HIFU center. It's just a small room, nothing fancy. It doesn't require any anesthesia. It's not a sterile room. It's just a normal room where the machine is here, and this is the console, and this is the water system. This supplies water and electricity to this machine. So it's a small room, and so the HIFU center is in here. Now, before I give you all some examples of patients that I've done, I will explain to you this volume of uterus. So this is a study that shows what is a normal volume of the uterus of a woman, and it is actually between about 15 to 56 centimeter cube in a normal uterus. In a 12-week size uterus in a non-pregnant benign, it is about 240 centimeter cube. Now, this is important because we have no idea what is the volume of a uterus when we see patients. We measure dimensions only, but volume is important when we treat patients with adenomyosis. And here you can see a nomogram. A patient who is 37 years of age, her at 5th percentiles, the volume is 27.3, and at the 90th percentile is 235 centimeter cube. Average 50 percentile is about 80. So the average uterine volume is around 80 to 85 centimeter cube. So now let's look at some case studies. Now this is the first case. It's a 38-year-old lady, para 2. She was noted to have adenomyosis before a second pregnancy. Adenomyosis started getting bigger during pregnancy, and she was given generation analog and then Mirena in 2019. It was increasing in size over the last 6 months from 3 centimeters to 5 centimeters. Pain from the left groin pulling to the leg and now on the right side. Periods were prolonged, and she's gaining a lot of weight with Mirena. And this is how it looked. This is a typical adenomyosis. In fact, yesterday I did 2 cases like this. Typical adenomyosis patients with the whole adenomyosis in the posterior wall. This is the whole adenomyosis in the posterior wall. And this is how it looked before HIFU. This is called the contrast MRI, where there's blood flowing into all the uterus, all the uterine muscles. And this is after the HIFU. After the HIFU, we did the MRI. And you can see these dark areas are the ablated areas. This is an ablated adenomyotic lesion. This is an ablated adenomyosis lesion. And so the post-HIFU volume was 133.67 centimeter cube. And this is after, this is before the surgery. Before HIFU, her volume was 273 centimeter cube. This is, I think, 1 month after the surgery. This is the volume, 133.67. So there was a 53.6% reduction. Most patients, it will take about 3 months to reach about 50% reduction. But remember that this is reduction of the uterine volume, not the adenomyosis. And you can see that 133 is just probably slightly bigger than the normal uterus, which is actually 80 centimeter cube. This case number 2, 40-year-old lady married for 7 years and not keen on pregnancy, severe dysmenorrhea for the last 4 years, heavy periods. And again, this is how it looks. You see there's a huge adenomyosis here. There's a huge adenomyosis. And so this is, sometimes we don't do MRI all the time. We do ultrasound. We do what we call as a volume measurement of ultrasound. So this 28th of August, her volume was 112 centimeter cube. And this is on the 23rd of September, which is about a month later. There was a 38.5% reduction in the volume. It becomes 68.81 centimeter cube. This is case number 3, 41-year-old single lady, adenomyosis for 20 years. In 2010, we did a lab myomectomy and placed the Mirena in 2012, but removed in 2016. She's on GnRH analog. She's given 3 injections. Severe dysmenorrhea and heavy menses. Examination and ultrasound showed a uterus of 16-week size, bulky, thickened posterior wall resembling adenomyosis. There was a right adenomyoma, endometrioma measuring 2.25 and 2.67 centimeters. And this is how it looks. You can see a typical adenomyosis, large adenomyosis lesion here, large adenomyosis lesion here. This is before HIFU. This is the day after and after HIFU has been done. So we have ablated adenomyosis. Now we cannot completely ablate everything. It's not possible because we have to have margins. And so we usually ablate about 60-70% for adenomyosis. Fibroids, we can reach 80 to 90%. Adenomyosis is a little bit more difficult because it's very dangerous. Usually there's bowel adherent behind and also endometrium in front. So this is a post-HIFU contrast. So when we measured the volume after 1 month, there was a 64.3% reduction in the volume. The case number 4 is a 43-year-old lady married for 7 years, para 0, IVF done in 2017, 4 embryos transferred, FET done, she was not pregnant, she has dysmenorrhea, she takes acoxia and heavy periods with clots. And again, you can see This is the adenomyosis here. This is more of an internal adenomyosis. You can see that it's already reaching the endometrium. When such adenomyosis reaches the endometrium, pregnancy rates are quite poor, but we try our best. And you can see the adenomyosis here. If you can see the junctional zone is even better. If you can see that if the adenomyosis is here and with the junctional zone, the success of pregnancy is better. So here, this is how it looks, the contrast MRI. And here, after ablation, we have ablated. We have to spare the endometrium. This is the ablation. And so we are waiting for her uterus to shrink. So in conclusion, adenomyosis is a very difficult problem. It is more difficult when the patient wants to conceive. And all of y'all are, I'm sure, IVF specialists, and I'm sure you have this kind of patients that don't know what to do with them. And HIFU can be used in both patients who want to conceive and those who want just relief of symptoms. And studies have shown that success rate in reducing menorrhagia and dysmenorrhea is up to 85%. This is very well known. So if you are only looking at heavy periods and pain, your success rate is high. But we IVF specialists, we have one more factor, which is can they get pregnant? That is a big issue. So, but not all adenomyosis cases are the same. In some, ablation is easy. In others, it can be very difficult. I recently had 2 patients whom I ablated, and it didn't burn the disease. The reason is because the adenomyosis were full of lakes, and we can only burn around those lakes of adenomyosis. So not all adenomyosis are the same. Some can be very difficult. However, HIFU is a good option for patients who want to retain their uterus. Okay, that's all my talk. I didn't prepare a long talk. If there's any questions, I'll answer.
Very interesting and very presentation. Sir, I ask you. Sir, this is
yes,
this is an outpatient procedure, right? So, how much time is needed? Actually, sir?
Okay, actually, in Hong Kong, they do it as an outpatient procedure. So what they do is they admit the patient early in the morning, and then they do the case in the morning, and evening the patient goes back. We are not doing it as outpatient. We are doing it inpatient. Basically, 2 reasons. First reason is that many of my patients are from outstation. They come from all over Malaysia, and they come one day before, and then they get admitted, and then do the procedure, and I'll send them one day later. So usually they admit for 2 nights. The other reason is because all our patients are insurance patients. Insurance want them to be admitted so that they can claim. So that's the reason why we are admitting. So our average admission is actually 2 nights. We can actually do it with 1 night, but sometimes for convenient purposes, we are admitting them for 2 nights. So that's basically it. So it actually can be done as a day care procedure.
You're also excellent laparoscopic surgeon. If you compare the laparoscopic surgery and the HIFU in terms of cost, actually, which is the better option for the patient?
Okay, as I said, I always tell my patients that we do not charge more for HIFU compared to laparoscopic surgery. We are charging the same. The cost is the same for both HIFU and for laparoscopic surgery. But of course, our cost may be higher than what Bangladesh is or India is. Our Malaysia, for example, Singapore cost is 3 times more expensive than us, both for HIFU and for laparoscopic surgery. Similarly, Hong Kong is about 4 times more because the cost of living is higher there. So I always tell them that we have both, each one costs the same, whether you do HIFU or you do laparoscopic surgery. As for fibroids,
you are the gynecologist here. Actually, in our subcontinent country, there's a debate that this procedure actually who will do, gynecologist or the radiologist?
Yeah, this is the biggest advantage of HIFU. This particular machine. This particular machine is an ultrasound-based HIFU, so I do it myself. That's a big advantage. So I am in control of the whole situation, as opposed to if you want to do MRI-based HIFU, it's only done by radiologists. So the big advantage of ultrasound-based HIFU is if you are comfortable doing ultrasound. I'm sure in Bangladesh you all do your own ultrasound for gynecology. I think in India sometimes they send to radiologists. If you are doing your own ultrasound, you can learn to do ultrasound-based HIFU on your own by yourself.
You're also, sir, IVF specialist. I want to ask after HIFU, how months later she will go for frozen embryo transfer? Actually,
yeah, it's a good question. In fact, I saw one patient today after doing my HIFU. I would say it all depends on where you start. If your uterus is 20-week size, it's going to take some time for it to shrink down to at least 12-week size before 14 to 12-week size. That would say 6 months, probably 6 months or 8 months. If it is a uterus that is 14-week size, then it will shrink by 4 months. It should shrink down to about 12 weeks or even in fact bulky uterus. So I would say in the region of 4 months to 6 months, you should be able to do a frozen embryo transfer. So we will monitor. I'm also new to this. As I said, I'm only been doing for 5.5 months. And I actually today saw my first HIFU patients. Her uterus has actually shrunk. It still hasn't shrunk to very small, very, very normal size. She wants to get pregnant on her own. And we are now working to help her to get pregnant. So I would say 4 to 6 months will be the time. But you need to see whether the shrinkage has come down to a reasonable size for you to do embryo transfer.
Thank you, sir. It's an excellent presentation. We learned a lot from you, sir. Thank you again, sir. You are so busy. You are now OPT, so lots of thanks to you. You are a great teacher of mine. Thank you, sir. Thank you for joining our show. Thank you, sir. You can leave, sir.
Okay, thank you. Thank you. Okay, bye-bye.
Bye-bye.
Okay, see you then.
See you. Bye. Vijay.
Yeah.
You can share your.
Yeah. Can you see the screen now?
I got. Yes.
Already done. Fine.
Fine. So again, Vijay Pawer now is going to present single versus dual trigger in assisted reproductive technology. So Vijay, you can start.
Yeah. Very good afternoon. I am again in the conference for the presentation. I thank Anam for giving me this opportunity. So today's topic given to me is dual versus single HCG trigger. So we all know that in the mammalian species, whenever there is ovulation, there is a surge of both LH and FSH. So this is a very important thing to remember, that there is a surge of FSH plus LH. And when we give an HCG trigger, it generally acts as an LH surrogate. So there is no FSH surge when we give an HCG trigger. So when this both FSH and LH surge occurs, it helps in the final follicular maturation with the loss of gap junctions between the oocytes and the cumulus cells. There is cumulus expansion, germinal vesicle breakdown, and resumption of meiosis and luteinization of the granulosa cells. So all these things to happen, you need both LH and FSH. So conventionally, when we are giving HCG, it is going to act more like a LH surrogate. The general dose that we use for the trigger is between 5,000 to 10,000 units, international units, or we can use a combination of trigger, that is the HCG and the GnRH agonist. So this in the last 5 to 10 years, this concept of giving HCG and GnRH agonist basically started. So HCG only trigger 36 hours before the oocyte, we know. And there is another when we want both.
Sorry, Vijay, can you move the camera down, below down? Actually, your face not so visible. Oh, very
now.
Fine.
Okay.
Continue.
Yeah. Sorry for the disturbance. Okay. So when we give a GnRH agonist trigger, it is going to cause both the LH and FSH surge. And whenever there is a both LH and FSH surge, we will get a better result. So this has been already been proven that now GnRH agonist triggers are either equivalent to HCG trigger, or they are better to than the HCG trigger. So, but the problem sometimes occurs is the poor luteal phase support. So that is the problem that people have tried to compensate by giving low dose HCG and giving a aggressive luteal phase support. So these were the two things that we should know. First is a single HCG trigger or the only GnRH agonist trigger. So if we compare both of these, as we have said, they are both equivalent, both have their own plus and plus points as well as negative points. So whatever negative points of HCG agonist trigger are there, that can be rescued or cured by giving an HCG along with GnRH. So this was the basically concept that was used for using the dual trigger. So when the research started of the combination of the agonist plus the HCG trigger, it started especially in poor responders in IVF. So whenever you got a poor oocyte quality eggs or the Poseidon group 4 patients, in those cases this trigger was first started, and then the study came into the normal responders. So in the normal responders, if you see in this study which was published in 2013 in the Fertility Sterility Journal, where you can see this is basically a retrospective study of around 376 patients, where they did a dual trigger for oocyte maturation, and they found that as compared to the HCG trigger, the results were a bit better. So this was, but again there were controversies that this is a retrospective study, it is not matched. So in 2016 and 17, this another study came where the dual trigger for final oocyte maturation of combination of agonist plus HCG versus HCG alone was used in GnRH antagonist cycle. So mind you very well to remember that dual trigger cannot be given in long protocols. It has to be used in GnRH antagonist protocols only. So first study was a retrospective study. Then there was a systemic review and a meta-analysis that was done. In this meta-analysis, there are 4 RCTs that were taken. Around 527 of the patients were taken, and the results were tried to compare. Again, in this study, it was found that the dual trigger improves the reproductive outcome. But what they suggested in the study that this is still a randomized control study. It needs an double-blinded study. So recently, in 2020, this study has come in the human reproduction, which has nearly answered to our question of whether HCG is better or the dual trigger is better. So this was a prospective randomized double-blinded study in the normal respondents. Okay, so in hyperstimulated OHSS risk patient, we generally don't use dual trigger. There we are going to only use the agonist trigger. That is already sorted out. So the study question is whether to use dual or a single trigger in a patient, normal responder patient. So this is the study that was done. That is a GnRH agonist versus HCG, which was uh, published in Human Reproduction last year, that is 2020, during the COVID times. So we can see this study, the sample size required was 276, but the interesting part is that they did only 155 patients. So why did not they take the another 50% of the patient? This study will answer. So all the data were matched for the age, BMI, AMH, and they were divided into 2 groups of equal number of patients. In the HCG group, there were 78 patients. In the dual group, there were 77 patients. So age was matched, the body mass index was matched, the gravity was matched, the parity was matched, the indications for IVF was nearly matched. The unexplained infertility in both the groups was quite similar. Male factor infertility was similar. The AMH of the patients taken one on an average was in the normal responder group, as you can see in this slide. So what protocol was used? So generally the antagonist protocol was used. Day 3, the FSH was started, and when the lead follicle reached around 13 millimeters or the E2 reached around 1200 picomoles per liter, GnRH antagonist cetrotide 0.25 mg was started, and if required, Luveris for LH support or HMG as a LH surrogate was added if required by the consultant. Now this follicular monitoring was done, and around when the follicle reached around 20 millimeter size, the patients were double blinded. So here nobody knew, neither the nurses, physician, embryologist or the patient knew what was given. So in the case of the dual trigger, the envelope contained the HCG plus agonist, while in the other group, that is the only HCG group, they received one HCG and one placebo injection. So the nurse also did not know which patient is receiving the dual trigger and the HCG trigger. So basically, double binding was done. Only the study coordinator had access to the coding of the syringes. So this way, it was a randomized controlled double-blind trial. And most important, whenever you give dual trigger, what subluteal phase support has to be given. So here you have seen HCG is given along with agonist. So 200 microgram of micronized progesterone by vaginal route 3 times a day was started. for the patients. So if you compare this cycle length for the stimulation, it is around 11 days in both the groups. The total dose of gonadotropins was around 3000 in both the groups. The E2 level on the day of trigger was around 6800 in the HCG group, 800 in the 8000 in the dual trigger group. The number of follicles more than 10 millimeter on the trigger day in HCG group was around 14, same in the dual trigger group, and the number of follicles more than 15, which is again important, is around 9.2. So whenever the follicles are more than 15, that is more than 15 or 15 follicles, we generally don't use HCG. So basically, this is what they had done. So again, the cleavage stage embryos more in the dual trigger group, good quality blastocysts more in the dual trigger group. So compared to the pregnancy, now when we compare to the pregnancy, very important to see that the top quality embryos were more income in dual trigger around 65%. The clinical pregnancy rate was nearly double in dual trigger group. The clinical pregnancy rate per patient was around 57%. Live birth per transfer around 36%. And if you combine everything, that is the cumulative live birth per pregnancy, again it was more 45% in dual trigger group and 32% in the single trigger HCG group. So from this study, we all have understood. Now the question is quite uh, solved, that in the dual trigger gives us better number of oocyte, more number of blastocysts, more number of top quality blastocysts, and it also increases the number of live birth rates, and we also have extra spare embryos left in case there is failure, because we can do a frozen embryo transfer. So that is, this is how the question has now been raised, that dual trigger group is a better option in normal responders. Mind you, in high risk for OHSS, dual trigger should not be used because HCG is generally, because we are going for OHSS preclinic. So HCG should never be used in cases of high risk for OHSS. So the take home message here will be that dual trigger is better in poor responders and normal responders, and agonist trigger for patients at risk of OHSS. I thank you for
Thank you.
giving me this opportunity.
Thank you, Vijay. That's you've already answered that pissus patient are the most dangerous, and if a number of follicle more, then dual trigger is difficult. So actually, in that cases, you only give the agonist trigger. Huh? I did.
Right. So now freeze all for all cases of OHSS. So most important is never see in IVF only two things can kill the patient. One is the over and hyperstimulation syndrome, and another is laparoscopy. So these are
Right.
the two things which can theoretically, or may land with a mortality in IVF. So
Right.
if you avoid doing laparoscopy and don't use cause OHSS in your clinic by going for agonist trigger, your life is very simple, easy.
Simple.
You know, you can
Right.
have a
That's
good
the
night's
tricks.
sleep in the night.
That's the tricks in the IVF, right? Thank you,
Yeah.
Vijay.
Thank
I
you.
hope your excellent presentation and you have covered everything of the topics. So hopefully see you next day. Okay. Thank you.
Thank you. Thank you. Bye.
Thank you. Bye. Hi, Angel.
Hi,
How are you?
I'm good. Let me share
Uh,
my slides.
Sorry, it's late now.
But that's okay.
Now you can share your screen, no?
Oh, yeah.
Okay.
It's not sharing.
Now just share.
Uh, I have a problem with sharing. Yesterday it worked. I mean,
Or
the other
just
day, right?
open your PowerPoint first. Okay. Just open your PowerPoint presentation first. Then go to share option.
No, I'm good. Okay, it's sharing now. I mean, it's uploading.
Okay.
I made the file smaller so it will upload fast, but it's still taking some time. Sorry. Sorry for the delay.
Mm. No, no, no. Don't be hurry.
Anyway, thank you, Anam, for inviting me. So,
Thank you. You have enlightened our
congratulations.
show, and I know you are very busy.
Uh,
You have joined, and you just listen our topics, no? You're waiting in the queue.
you have a large lineup of guests, so congratulations.
Thank you.
Sorry, it's still processing. So just a few seconds.
Okay. Okay. Can you go in a simple way? Just first open your PowerPoint, then go to share, and this is a simple way to connect.
Yeah, but it's not PowerPoint, it's PDF because it's a smaller file if I use PDF. So I remember last time we did this, it worked. So now I'm doing the same thing but with a smaller file, so it should be faster. Maybe we can start with the Q&A.
No, it's visual is very important. No.
I know, sorry. So how many are I mean your audience consists of how many people right now?
It's actually in live telecasting in Facebook, YouTube, and some television channel also. So I
Oh my.
exactly don't know how much viewer is there.
So this is just made me more nervous, right?
No, 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 no. Be cool, huh?
Well, it's still processing. I'm so sorry.
You just open your PowerPoint, nah. That don't share the PDF file. You just show your PowerPoint
No,
slide.
it's not in PowerPoint. It's in Keynote. So it doesn't accept Keynote. Wait, let me see. Or you want the next speaker instead of me?
No,
Or
no, no. You are the last speaker now. Then we will go for
wait,
lunch.
let's see. Um, this file is just a small one. It's just 16 MB. I don't know what's taking so long. Uh, can I stop sharing the PDF and try the PowerPoint? I just, oh, there, it's working now. Okay, I'll start. So again, I'd like to thank my good friend, Dr. Anamul Haq, for inviting me to be part of this prestigious Congress. I will begin my lecture with a case, and that of a 41-year-old woman who presented with an 8-centimeter intramural fibroid and was strongly desirous of pregnancy. She consulted with 3 OBGYNs, all of whom
Angel,
are,
Angel,
yes.
Angel. I would just like to introduce you first. Then you start. Okay.
Okay, go, by all
Good.
means.
The angel is actually Regina Tan Angel, angel from Philippines, Manila. She's very famous there. She's
Okay.
our good friend, and she's a very good laparoscopic surgeon and also fertility specialist. I am very delighted that you have joined my show, and we are very lucky. And now you can present your topics on role of myomectomy in infertility. Angel,
Okay.
you can start.
So I'm beginning with a case of a 41-year-old woman who who presented with an 8-centimeter intramural fibroid, and she was strongly desirous of pregnancy. Now, after seeing 3 OBGYNs, all of them advised her hysterectomy. Now, at this day and age, especially during the pandemic, when we have free access to online learning and numerous webinars, I was still surprised that there are still OBGYNs, at least in my country, who think of hysterectomy as the only solution to large fibroids, even in women desirous of pregnancy. Now, I know, I hope it's not the same in your country. So, granted that this patient is 41 years old and it's probably have difficulty getting pregnant with or without a myoma, that decision of a hysterectomy is not ours to make. As you know, as doctors, we are here to offer them options to preserve and enhance their fertility and not take it away from them. And so for this afternoon, I'm Dr. Angel Tan Espiritu, and I will walk you through the role of myomectomy in infertility with its indications and technique to enhance fertility. Now tell me if I'm talking too fast. So this is my disclosure. I have nothing to disclose. Now, let's begin with some basic facts about fibroids. So, we all know they are the most common benign tumors affecting women, and they're also the most common indication for hysterectomy. In fact, in a database study in the US among women treated for fibroids, a whopping 63% of women underwent hysterectomy, while only 11% were offered myomectomy. And also, depending on which paper you read, the incidence of fibroids can be as high as 70 to 80% of women, and that's roughly 8 out of 10 women statistically. Now, let me share with you a bit about history. For Dr. Victor Bonney, who invented the Bonney's myomectomy clamp, he was an OBGYN resident back in 1901. That statistic happened to be his wife. She underwent hysterectomy for bleeding submucous myoma upon the advice of a senior consultant, thus preventing her from having children. So this setback led to Bonney's lifelong advocacy for the more conservative surgery of myomectomy. Now, in my humble opinion, I think myomectomy is one of the most complicated, tedious, and time-consuming gynecologic procedures, but it's also the most rewarding. And so I hope we can all become advocates of myomectomy just like Dr. Victor Bonney. Now, these are my learning objectives. I'd like to determine the patient profile of those who will benefit from myomectomy to enhance fertility and discuss some available treatment algorithms. I'll just briefly run through the basic approaches to myomectomy and suggest some surgical considerations to enhance pregnancy outcomes. So first, let's look at the impact of fibroids on infertility. So fibroids may cause infertility by obstructing the fallopian tubes and impairing gamete transport. It is now clear that the critical factor may be the distortion of the endometrial cavity, causing abnormal endometrial receptivity, hormonal milieu, and altered endometrial development. One or more mechanisms may be present at the same time, contributing to varying degree to fertility impairment, such as affecting fertilization and/or implantation. Studies show that fibroids are present in 5 to 10% of infertile women, with only 2 to 3% having fibroids as the sole cause of infertility. Okay. So, which brings us to part one of my discussion: who will benefit from a myomectomy? So let's move on to case number 2. She's a 32-year-old doctor who was strongly desirous of pregnancy, and she underwent open myomectomy for a 3-centimeter intramural fibroid located at the posterior lower uterine segment upon the recommendation of her OBGYN. 2 years post-surgery, she had an ectopic pregnancy and was referred for laparoscopy. Our intraoperative findings revealed severe bowel adhesions covering the entire posterior uterine wall where the myomectomy scar was, and both adnexae could not be visualized due to because they were hidden beneath dense adhesions. Unfortunately, instead of enhancing her fertility, the myomectomy did the opposite. And at the size of 3 centimeters, you'd think, was a myomectomy even necessary? So not all women with fibroids and infertility will need surgery. So how do we decide? So in order to identify which women will need surgery, the FIGO leiomyoma subclassification system was created to categorize fibroids based on anatomic location. At present, there is no classification system that includes additional parameters such as fibroid size or number. But do take note that this was created to assist in classifying and treating AUB, and it's not clear if this classification system will assist in a better understanding of the effects of fibroids on reproduction and pregnancy loss. So this next paper will do just that. Okay? So this is a meta-analysis of 23 controlled studies, and this nicely summarizes the impact of fibroids on fertility based on their location and the effects of myomectomy in improving outcomes. The authors demonstrated that submucous and intramural fibroids had a negative impact on fertility, while subserous fibroids made no difference. And they also showed that the removing submucous fibroids improved one's fertility, while myomectomy of subserous fibroids offered no change. Whereas for intramural myomas, the evidence was unclear. Now, this is a big gray area since despite the findings that intramural fibroids decreased fertility, there was not enough evidence to show that removing them enhanced it. However, these reports did not take into consideration the size and number of myomas and whether they encroach on the endometrium or not. Okay. So I searched for papers on intramural fibroids that look into these potentially predictive variables. And to summarize this rather busy slide, the studies show that size negatively influenced fertility, and both cavity and non-cavity distorting intramural fibroids were also shown to have a negative effect. However, surgery seemed beneficial only for cavity distorting fibroids. And according to the ACOG and ASRM guidelines, myomectomy is indicated in patients with infertility or recurrent pregnancy loss after excluding all other causes, or in patients with the presence of a markedly distorted cavity. It's also indicated in symptomatic patients desiring to maintain fertility. Now, I also summarized both guidelines on the management of fibroids in women with infertility released by both the SOGC and ASRM. And these will help us identify those women who will benefit from myomectomy. And the bottom line is surgery is not indicated in women with subserous fibroids and those asymptomatic women with asymptomatic non-cavity distorting intramural fibroids. However, surgery may be considered in asymptomatic women with cavity distorting myomas and those women with severe distortion of pelvic architecture obstructing oocyte retrieval during IVF. Surgery may also be considered if the patient has no other options or other causes for infertility have been ruled out. But the benefits of myomectomy should be weighed against risk. And the management of intramural fibroids should be individualized based on the number, size, location of fibroids, and skill of surgeon. Now, I'd like to share with you some treatment algorithms for the management of fibroids and infertility. This is an algorithm for the management of fibroids in general. So for women who are symptomatic, clinical surveillance is advised, but focus on the lower part of the algorithm. And I'd like to emphasize this part. Now, if the woman is symptomatic and wishes to preserve her fertility, or if she wishes to preserve her uterus despite having completed her family size, then we have to respect that. And myomectomy is the surgery of choice, not hysterectomy. Now, if the patient no longer wishes to preserve her uterus or is postmenopausal, that's when hysterectomy becomes an option. Now, this is a 2016 algorithm which applies to women with fibroids and presenting with infertility. So for submucous myomas, especially those with AUB, hysteroscopic excision is recommended. For intramural myoma, especially those bigger than more than 4 centimeters, excision is recommended, preferably laparoscopic myomectomy. But for intramural myomas less than 4 centimeters in size and subserous myomas, expectant management is advised, except in symptomatic cases or those with multiple IVF failures or poor obstetric outcomes. Okay. For this next slide, this picture above is the classic drawing of the FIGO leiomyoma subclassification system I showed a while ago based on location for the management of AUB. So the fibroids, as we all know, are classified into submucous, intramural, subserous, and everything else in between. But the picture below is a reinterpretation of that diagram by Professor Donay in 2020, clearly depicting the relationship between myomas and myometrium, and this time to address infertility. So Professor Donay reported that the negative impact of intramural myoma is related to myoma size and proximity of the uterine cavity. He proposed a new algorithm for intramural myoma-related infertility, incorporating medical treatment as a primary approach. So in this 2020 algorithm by Professor Donay, for intramural myoma-related infertility, if the myoma is less than 3 centimeters, then expectant management is advised. But if it's more than 3 centimeters, instead of surgery, medical treatment with GnRH is proposed as the primary approach to decrease the myoma size and push it back deep into the myometrium. If it is effective, then the patient can proceed with IVF or natural conception, but if there is no reduction in size, then surgery is offered. Now, I had the chance to listen to Dr. Binarwan Halim from Indonesia, who gave a very comprehensive algorithm for women with fibroids who are for IVF, and I'd like to share with you. An important aspect of this algorithm is the consideration of the patient's age. So this is crucial because we don't want to delay ART for women 35 years old or older, or those with poor ovarian response if they need surgery. Okay. And another salient feature of this algorithm is the incorporation of the hybrid approach. So for patients more than 35 years old requiring surgery, he recommended the hybrid method. And this is wherein the patient undergoes oocyte retrieval and embryo cryopreservation prior to myomectomy. This will allow the patient to heal without feeling anxious about delaying her embryo transfer and her declining ovarian reserve, since she already has embryo stored. So after recovery, that's when they perform the frozen embryo transfer. So for the general OBGYNs in the audience, if you have patients you want to refer for IVF, it would help to refer to the patient right away without doing the surgery first to your partner infertility specialist, who can assess if your patient will need myomectomy prior to IVF or vice versa. So now we move on to the various approaches to myomectomy. I'll just briefly go through these. Okay, so these are the various techniques for myomectomy. So we have open myomectomy, lap myomectomy, robot-assisted myomectomy, lap-assisted myomectomy, and hysteroscopic myomectomy. I'll be focusing on these first three and briefly discuss the risks and benefits of each. So this is a 2017 study comparing all three approaches to myomectomy and showed that open myomectomy was superior in terms of least operating time and cost, but both robot-assisted and laparoscopic myomectomy offered the least blood loss, had less complications, and less duration of hospital stay. However, robot-assisted myomectomy had the highest operating time and cost compared to all three. After all of these considerations, I believe that the statement by Professor Herman and de Wild in an earlier paper still holds true, and that is, in women with symptomatic fibroids desiring to preserve their fertility, myomectomy remains the gold standard therapy, and laparoscopic myomectomy should be the gold standard procedure. Now, with regards to the pandemic, at the start of the pandemic in 2020, it brought special concerns between our choice of open versus laparoscopic surgery. But a lot of things have changed since a year ago. Particle count studies show that there is less surgical smoke transmission with MIS, especially with the plume being confined within the abdominal cavity and is more safely dissipated through smoke evacuators. So current recommendations show that the MIS approach would be safer for the operating team while the patient enjoys the benefits of MIS. And that laparoscopy should not be replaced by laparotomy due to COVID-19 if there is no other clinical indication. Okay. So when it comes to choosing the right patients for laparoscopic myomectomy, the indications would be the uterine size less than 16 weeks, dominant fibroid less than 15 centimeters in greatest dimension, and a number of fibroids should be less than 5. But then fibroid size criteria will depend on the surgeon's skill and level of comfort. Okay. And in larger, more numerous fibroids, or those fibroids involving the broad ligament, uterine cornea, or uterine vasculature, endoscopy can still be done, but it should be attempted by the highly skilled and experienced laparoscopic surgeons. Now, if you're considering or if you have a strong suspicion of uterine sarcoma, then opt for the open myomectomy with an oncologist on board for staging. Okay. Now, for those who are quite hesitant to perform laparoscopic myomectomy because it's time-consuming or there is clinical difficulty of tissue extraction or suturing, then I believe a happy medium between the two would be lap-assisted myomectomy. With LAM, you can augment your lap surgical ports with a mini lap incision, and this allows you to palpate the myoma, evacuate it through a slightly bigger hole, and suture the way you would with laparotomy. Now, personally, I prefer to do lap myomectomy, but if there are contraindications to doing so, or in difficult situations where I need to convert, then I would go for LAM instead of open myomectomy. Now we come to the last part, and I'll just have 2 or 3 slides on this. This will be the techniques to enhance fertility. And I don't think there's any one technique that per se that directly enhances fertility, but it's more of employing good operative technique in order to avoid complications that hamper a patient's fertility. And I believe that one way to enhance fertility is to avoid complications. And this 2018 paper by Thanos showed that complications arise due to incorrect patient selection, failure to limit time in laparoconversion, and surgeons' overconfidence in managing difficult cases. And so for myomectomy, complications might arise due to a growing number of gynecologists with unjustified confidence at myoma excision by MIS without sufficient training in laparoscopic suturing and electromechanical morcellation. And these might attribute to these statistics. Okay? And so training and experience are crucial to reduce such complications. With adequate training and experience, this provides us with a proper surgical strategy. And with such planning of the surgery or the procedure with proper port placement, this can determine the degree of ergonomic surgery performance, the time and quality of myoma enucleation and suturing quality. Appropriate hysterotomy length and relative to myoma size will also decrease bleeding, coagulation, and suturing times. Proper coagulation of large vessels using bipolar and avoiding carbonization, as well as proper suturing by avoiding myometrium gaps, would decrease the risk of myometrial hematoma. And quality surgery and the use of anti-adhesive barriers would reduce the risk of post-operative adhesions that greatly contribute to hampering one's fertility. And proper morcellation with in-bag technique and use of low intra-abdominal CO2 pressure would help reduce the risk of benign and malignant cell dissemination. So I hope this lecture helped you with decision making for myomectomy. So in summary, we have to consider the patient's age and give value to her desire for fertility. We also have to assess the location, size, and number of myomas. And lastly, we have to have an honest assessment of the surgeon's experience. We are the only ones who can judge for ourselves if we are qualified for the task or not. And so when we have patients who are strongly desirous of pregnancy despite having large fibroids, please do not recommend hysterectomy. But also, if the fibroids are not that significant, do not offer myomectomy if it's not needed. Okay,
Right.
and an essential part of learning myomectomy is this discipline of knowing when to practice the skill and when to practice restraint. So I'd like to close this lecture with a quote from Dr. Victor Bonney. Since cure without deformity or loss of function must ever be surgery's highest ideal, the general proposition that myomectomy is a greater surgical achievement than hysterectomy is incontestable. So I think this is it. So congratulations to my good friend Dr.
Thank
Anamul
you.
Haq for organizing a very successful international conference.
Thank you,
I'm most
Angel.
honored
Yes,
and
so
humbled
nice and so beautiful
at
presentation you
this
did. You
meeting. Thank
almost
you.
cover everything, but I have one question.
Yes, only one.
You have seen the lectures of the Dr. Silva from Malaysia. He's
Uh,
conducting the high intensity focused ultrasound on myomectomy or adenomyosis.
Unfortunately, only part of
Uh,
it.
have you any comment on about HIFU?
Yeah, I don't have experience in HIFU. It's not there have been parts of some doctors in the Philippines who want to bring it here, but we don't have a machine for that. But I think it's promising. From what I've heard and learned about it so far, I think it will be a good alternative, especially for women who are not good candidates for surgery.
Right, right. That's good. Yeah. Okay. So thank you, Angel, and you have enlightened my show. I'm very grateful to you, and you are so busy, and you have given me time. Thank you,
The
Angel.
honor
Thank
is
you.
mine. Thank you so
Okay.
much.
Thank you so much. Thank you.
Thank you.